Welcome to Understanding Parkinson's Disease and Mental Health in the Veterans Community. Today's webinar is proudly presented by the Parkinson's Foundation in partnership with the U.S. Department of Veterans Affairs, Parkinson's Disease Research, Education, and Clinical Centers, otherwise known as PADRECCs, and the Veterans Health Administration. Hello, everyone. My name is Dr. Tracy Westridge, your moderator for today's program. I'm the nurse executive at the Veterans Health Administration National Center for Healthcare Advancement and Partnerships, or HAP for short, under the Discovery, Education, and Affiliate Network, or DEAN office. At HAP, we serve as a trusted resource and a catalyst for the growth of effective partnerships at the national, state, and community level and advance the health and well-being of veterans through exploration of innovative, safe, and ethical emerging therapies. Partnerships such as this one with the Parkinson's Foundation are force multipliers, enabling the Veterans Health Administration to improve the health and well-being of more veterans, their families, caregivers, and survivors. For those of you who are tuning in for the first time, we're so glad to have you here. Since 2020, the VA and the Parkinson's Foundation have partnered in the effort to reach more veterans living with Parkinson's and their care partners in order to provide the tools, information, resources, and support that the veteran community needs to live better and healthier lives with Parkinson's disease. Today's webinar, focused on mental health and Parkinson's, will begin with a short presentation with highlights from a survey conducted by the Parkinson's Foundation with the veteran community, after which we will hear from a veteran living with Parkinson's about his experiences with mental health and accessing support through the VA. Then, during a presentation from a VA physician, we'll learn more about the relationship between mental health and Parkinson's disease. And finally, we'll end the program with a question and answer panel responding live to your questions submitted through the chat. Before we get started, though, there are a few webinar tools and features I'd like to point out. The question and answer icon is located at the bottom of your screen. This is where you can type in your question or message us if you have a technical difficulty. We will answer as many questions as we can toward the end. And if you open your chat box now, you'll find the link to download the slides to today's webinar. This webinar is being recorded and will be available on demand early next week. All those registered will receive an email notification with the link. It will also be available on the Parkinson's Foundation website at parkinson.org/VA 2022. If you would like to download a copy of the slide, please use the link that is in the chat box right now. Finally, we're trying out a new closed caption feature on Zoom. Keep in mind that this is not perfect and there will be errors, but we hope that this option will help make our programs a little more accessible. If you are joining using a phone or tablet, you should already start to see the captions as I speak. If you're on a computer, hover the mouse toward the bottom of your screen and click Live Transcript, or CC for closed caption. You can then click Show Subtitle. Now it is my pleasure to welcome our first guest speaker, Shira Rosenfeld. Shira is the Vice President of Strategic Initiatives at the Parkinson's Foundation. Shira leads the Parkinson's Foundation's partnership activities and is the point person in the Foundation's collaboration with the VA. Shira will speak today about the Parkinson's Foundation Veterans Survey.
Thank you, Tracy. Good morning, good afternoon, everyone. Thank you so much for joining. I wanted to share a brief update on a recent survey the Parkinson's Foundation conducted focused on veterans with Parkinson's disease, which was in part the basis for planning today's webinar. Next slide. The Veterans Survey was carried out through the Parkinson's Foundation program, PF Surveys. So just a little background on that. The Foundation launched PF Surveys several years ago to inform research on Parkinson's disease and to promote a better understanding of some of the most pressing needs and issues facing the Parkinson's community. PF Surveys is driven by the experiences and the insights of people living with the disease and their care partners, and helps ensure that real experiences are directing and influencing research. So estimates show that approximately 110,000 veterans with Parkinson's disease receive care through the Veterans Health Administration. But we also know that many veterans with and without Parkinson's receive their care through the VA and outside of the VHA network. The Parkinson's Foundation, as part of our partnership with the VA and our joint commitment to improving care for veterans with Parkinson's disease, conducted a survey in 2021 through our PF survey program of veterans living with Parkinson's. For this survey, we were interested in understanding health status, care experience, and healthcare use by veterans living with Parkinson's who received care both in and outside of the VHA system. Questions in particular were related to mental health, health and wellness, referrals, and other areas of utilization and satisfaction with their care. And one of the main goals was to better understand what areas of care can and need to be improved to provide the best care possible and support for veterans living with PD. Next slide. So there will be a manuscript about the survey that will be released later in the year with many more details and discussion on some of the key findings, but it was clear from the research that there are some real gaps in knowledge and information as it relates to mental health and needed education, all of which were really drivers in planning today's webinar. The survey provided insights into the need to educate the veterans community on mental health symptoms related to Parkinson's and how to recognize those symptoms, where to go for mental health treatment and support, and what that treatment might look like, the importance of talking to one's provider about their mental health on the good days too, and really having an open, honest dialogue, and an understanding and awareness of mental health resources for veterans and veterans with Parkinson's disease and care partners from the VA as well as the Parkinson's Foundation. We hope some of these calls to action are part of what you take away from today's webinar, including the understanding the importance of getting early referrals and treatment for mental health, understanding the types of care that veterans with Parkinson's can receive and are eligible for, whether that be through the VHA or elsewhere, and where and how to access good mental health resources. It was our goal to take some of this research and put it into action, which is what we are doing here today with our speakers and panelists from the VA, from the Parkinson's Foundation, and the veteran community to share their experiences and their expertise. So I'll now turn it back to our moderator. Thank you.
Thank you, Shira. That was great. Next, we get to hear from retired U.S. Marine Corps Sergeant Dr. Patrick Welsh. In this 5-minute video, Patrick talks about his service experience, his use of VA's mental health services, and how these services impact his journey with Parkinson's.
Hello, my name is Patrick Welch. I am a Marine Corps Vietnam veteran. I have PTSD, and I have Parkinson's disease from my exposure to Agent Orange. In the next few minutes, I will talk a little bit about my mental health and Parkinson's disease journey. No one, absolutely no one, goes to war and returns the same person. The things we see should not be seen by anyone. When I came home, I did not talk to anyone about my time in Vietnam. My stock answer was what you hear many veterans say: I'm fine. And we know that reply means they are not fine. Each day I would put on my business suit, my coat of armor, if you will, go out into the world and project confidence and an air of authority. Each night when I came home and removed my armor, I would collapse from the weight of the day. It took me 19 years to finally accept that I was not fine. I sought help from VA Mental Health and thus began my recovery journey. Today, I still take medication for depression, still continue with individual sessions with social work, psychologist, and psychiatrist. Late in 2019, I started to develop tremors in my left arm. As I have severe nerve damage from my wounds, I thought this was just more of the same. Going into 2020, the frequency of the tremors increased, and so did the severity. In March 2020, when COVID hit, my ability to get into the VA for an appointment with neurology was canceled, as no one was allowed into the hospital. I began to do more research and determined that I might have Parkinson's disease. There are 10 early signs of PD. Some of the symptoms I had were the tremor, loss of smell, trouble sleeping, and dizziness. I found out that the VA had formed the Parkinson's disease research, education, and clinical centers across the country in 2001. The research led me to the Parkinson's Foundation. The foundation had an office in my community, and I made contact with a gentleman named Chris Jamali, who provided me with a great deal of information and assistance. In October 2020, I was finally able to get an appointment with VA neurology and was diagnosed with Parkinson's disease. My reaction was how most of us feel when we receive a diagnosis of another disease. I became very depressed. PD can have an extremely negative effect on your mental health. We know that your mental health also can be detrimental to your physical health. Now, we know that PD is not a fatal disease, but it can have an extremely negative effect on your quality of life. My VA doctor prescribed razagoline and later carbidopa. A key factor in taking an aggressive approach to maintaining your quality of life is exercise. The VA and the Parkinson's Foundation offer many resources to get you engaged in exercise programs that will allow you to maintain a good quality of life. On the Parkinson's Foundation website page, there is a great bit of information on exercise programs that can be done in the comfort of your home. The VA Whole Health Program provides many types of exercise that can also be done in the home or also at VA Medical Center. The VA also offers programs for the spouses of veterans with Parkinson's disease. Exercise is a critical aspect of how you walk and your balance. Falling is a major negative aspect of Parkinson's disease and can lead to hospitalization. I personally am involved in Parkinson boxing therapy. We know from VA statistics that there are approximately 110,000 veterans with a clinical diagnosis of Parkinson's disease. My role as a volunteer with the foundation and the VA is outreach to the veteran community. Thank you.
Thank you, Patrick, for sharing your story with us. Patrick will join us again later in the webinar during the question and answer period. It is now my pleasure to welcome Dr. Laura Marsh. Dr. Marsh is the Executive Director of the Mental Health Care Line at the Michael E. DeBakey Veterans Affairs Medical Center and a professor of psychiatry and neurology at Baylor College of Medicine. Dr. Marsh will speak today about recognizing mental health symptoms, treatment options, and communicating with your providers. Thank you, Dr. Marsh.
Thank you. Thank you for having me. And I am putting my slides on the slideshow. And I will do the display settings. Just 1 second. How's that? Is that everything okay? Yes, great. Well, thank you for having me. And it's really my pleasure to be here. I have a dual role where I am a psychiatrist who has spent her life working in Parkinson's disease and taking care of patients with Parkinson's and mental health issues. But I also have a role in which I oversee mental health care in our Houston VA, So it's really a pleasure to be able to put all that together for veterans, whether you're getting seen at the VA or not at the VA. So today we'll be talking about how you can, as a veteran, can recognize and manage your common mental health issues, and what your role is, and how you can work with your caregivers to optimize that experience with Parkinson's. So it's really important to understand how mental health symptoms emerge in the context of PD. I'll talk a little bit about that. I won't get into all the details of the biology, but I will mention that. Spend most of the time talking about treatment approaches and options for you, and then conclude with some thoughts about how to maximize and optimize your communication with your clinical team. So the first part, as I said, is to understand what symptoms are possible in the context of PD. And then I'll go over some common conditions so that if you have observed them in yourself, you can bring those up with your clinician. What's important to understand first about Parkinson's, and why maybe there hasn't been this emphasis on recognizing mental health symptoms, is because initially they weren't recognized as part of Parkinson's. When James Parkinson described the condition that took his name, he actually examined 4 patients, and 2 of them he had witnessed from outside his house, looking out the window of people walking on the streets of London. And you can see here, he talks about the tremor, the involuntary tremulous motion. He talks about the posture and how it tends to bend forward in Parkinson's. And he talks about how people walk differently, but he says very categorically, the senses and the intellect were uninjured. So the traditional view of Parkinson's continued on this way for quite some time. But as people lived longer, and we were observing things as Parkinson's could be treated with medications effectively, it became quite apparent that the traditional view of Parkinson's did not match the lived experience with the disease itself. And what you see is this progressive increase in attention and research on the mental health aspects of Parkinson's. And it's really, when you look at the total number of articles, in the 1990s, when I started doing this, there were maybe 40 to 50 articles at a year. Now there's over 2,000, 4,000 articles, coming out just in the last 2 years, and which is, so we've really seen this nice increase. And I think the next step is translating it into everyone's care, which I think that's why we're doing this today, is to help everyone get on the same page. So one of the first things you need to understand about Parkinson's is that mental health issues are also part of your Parkinson's. And what we know now is that mental health symptoms occur prior to your Parkinson's diagnosis. In order to have the diagnosis of Parkinson's, you have to have the 3 characteristic motor signs, which tremor, rigidity, and bradykinesia, and the disease has to be progressive. But before that occurs, you have to have sufficient degeneration of those dopaminergic neurons in your brain. Meanwhile, other things are happening in the brain that appear to be part and parcel of Parkinson's itself. And what we now describe as premotor or prodromal symptoms include depression, anxiety, loss of sense of smell, even constipation. But depression and anxiety particularly have been reported for quite some time. As you can see, these articles that I cite, or one of the first one is coming from 1997. What we see often is that on average, a depressive syndrome will precede Parkinson's diagnosis by about 4 to 6 years. With anxiety, we see that even more often. And this was something that I saw when I started seeing a series of Parkinson's patients. 2 to 3 years before they had the onset of Parkinson's, a patient would present with panic attacks or claustrophobia, et cetera. And as an adult psychiatrist, I know that those disorders don't come on when people are in their late 50s. They typically come on in adolescence, young adulthood. So this seemed very strange. And then I was seeing more and more people who had these kinds of reports. So the symptoms will either coincide with PD onset, or they'll present up to even 20 years before the motor signs. And when you look at large samples of just people in the general population, so 12-year follow-up of 35,000 men, even those people had high anxiety and reports of anxiolytic use, medicines like Valium or lorazepam, Ativan that people use to treat anxiety. Not that they should, but they have used it. Those were all associated with a relative increased risk of developing Parkinson's eventually. And this is data that just we keep seeing again and again and again. So prior to PD diagnosis, you see these symptoms. Even at the initial time of diagnosis, we can see symptoms that are consistent with a mood disorder. Now, this is data from 1967, which was shortly after we started having levodopa available, and so people started writing more descriptions of Parkinson's in a way that used actual data, and we're sort of parsing things out. Now, when I look at this, I look at, yes, tremor, gait disturbance, stiffness. Those are all pretty classic for Parkinson's, its initial symptoms in this 183 people. But other symptoms like slowness, muscle cramps, aching, depression and nervousness in particular, fatigue, decreased facial expression, those are all things that can go along with just the initial presentation of a depressive diagnosis. Now, and not every patient has depression or nervousness, but some people do. And one can imagine that it's quite, it can be difficult to separate what is Parkinson's versus what is depression. And the reason is you can't separate because they actually are going together. It's part and parcel of Parkinson's, and it's related to the brain changes that are occurring as well with Parkinson's. Okay. So when I looked at different conditions, specific psychiatric diagnoses that I would treat as a psychiatrist in a sample of patients, I had a study I was doing, and when I was working in Baltimore, we looked at 250 community-based individuals with Parkinson's. They did not have a dementia diagnosis, and we conducted full psychiatric interviews on these folks. Anyone can participate. What we found is that at the time that we met these individuals, 80% had at least one psychiatric diagnosis. The 20% were just lucky. I mean, they did not have any prior or current psychiatric diagnoses. The most common psychiatric diagnosis was some sort of mood disorder, in particular major depression. And the next common was anxiety disorders of various types, 40%, psychosis of various types, present in a little bit over 20%, impulse control disorders, about 15%, and 10%, excuse me, for the current, and very few people actually had substance use disorder. So when you see this really emphasizes that it's important for to have the mental health component be addressed as part of your ongoing care. And what makes that even more important that we're moving in that direction is because the data show that the mental health issues have tended to be undertreated. Now, that data that I showed you was from before 2010. And out of those 250 people, 97 had a major depressive disorder. So these are people, if I saw them, I would treat them with medications, but I also psychotherapy, exercise, a whole a panel of treatment options that I'll be talking about. But these were not my patients. And there were only 10% of those people, so about 10, who were totally, completely well-treated, asymptomatic, nothing more to do with them. They were doing fine. 63% were partially treated. And that's a big problem because we get people I had a patient one time who said, well, I got treated for Parkinson's, I got treated for depression. The doctor said depression was part of Parkinson's. He started me on an antidepressant, and I continued to be depressed because I figured it was part of my Parkinson's, just like you might still have some tremor. But in mood disorders and many other psychiatric conditions, we actually treat to get them under complete control, or that they can be managed. And so we really want to get it where this group of people who are partially treated gets fully treated. And even more so, there were 27% who their condition wasn't recognized at all. And so we see that if you look at the average duration of folks, it's, quite a long time. 182.4 weeks is that's several years that people have been suffering. And one of the reasons that's particularly important is because untreated mental health symptoms have a greater effect on quality of life as compared to the impact of motor symptoms themselves on quality of life. We also know, and as Patrick had said, that when you have mental health symptoms, they aggravate your motor and your cognitive deficits. They make disability worse over the course of PD. Your medical, it doesn't matter what medical condition you have, whether it's heart disease or lung disease. If there is a concurrent depressive disorder, that makes your medical condition worse. It also increases your risk of other psychiatric conditions and economic strain, caregiver distress, but fundamentally as well, just the suffering that the person goes through. And that's what we want to alleviate. So just to recap that, what I'm emphasizing is that when you think about your mental health conditions that are occurring in the context of Parkinson's disease, it's really important to think about how they're occurring over the entire course of PD. It's not just a cross-sectional time. And what we see here is if dopamine neuron loss starts back in say you're in your 30s, and by the time you get Parkinson's, you're about 60 years old, you wouldn't get your motor symptoms until later, but during that time, you might have episodes of depression, might have anxiety, you might have some sleep disturbances, something called REM sleep behavior disorder, which are very particular kind of nightmares that are sleep disturbance that people have. And then you have your motor symptoms that begin, but also people begin to experience pain or fatigue or some cognitive symptoms. And then over time, there are other symptoms that occur as the disease progresses, in particular, other cognitive problems, and then the development of psychosis. So it depends on where you are in your course of Parkinson's, in your journey, that we can look for things and try to limit their appearance, as well as treat them so that they can be better managed and your life is less affected by them. So looking at how we recognize these and what can you do on your own, what are the things that you need to think about? The first is when we're looking at depressive disorders, it's very important to remember that isolated emotions are not the same thing as a mood disorder. Patrick said when he got the diagnosis of depression, of Parkinson's, it led to him feeling depressed. Some people will get the diagnosis of Parkinson's and they said, I was so glad because I thought I had cancer. That's just, those are isolated emotions. Those do not equal a mood disorder. A mood disorder, they vary in severity and type, but the key feature is that the symptoms are pervasive and persistent. What you have to have, though, is a change in your mood or a change in your sort of ability to enjoy yourself or be interested in things. And I often find that many people, it's not about whether you can be happy, because some people can be happy in the moment, but still have the depressive disorder. Often what they'll experience is a decreased ability to enjoy things that normally they enjoy. So, and it might be as the simplest example, seeing one's grandchildren. Now, when someone gets to the point that they no longer can see their grandchildren and enjoy them, that's like really too far. If the only thing you're enjoying is their grandchildren in their life and everything else is still pretty blue, we need to really make sure that person gets treated for their mood disorder. So that this looking at decreased interest and pleasure is very important. You can have depression without specific sadness. So there are these physical symptoms of depression that are in PD as well as in depression. So appetite and weight changes, eating more, eating less, losing weight, gaining weight, sleep disturbances, sleeping too much, sleeping too little, moving slowly, fatigue, loss of energy, decreased ability to think or concentrate, being indecisive, questioning oneself, self-doubting. That can be in both conditions. Depression, what you're going to see is a certain kind of agitation or sort of agitation, or that can be pacing in a way that's also associated with the emotions. These feelings of worthlessness, excessive guilt, or thoughts that one's life isn't worth living, thoughts of death, suicidal ideation or even attempts or specific plans, along with the depressed mood or decreased interest or pleasure. So to recognize a depressive disorder, it's really important to look for the emotional features or to ask about them or to look to see whether you have them. So I've mentioned already sadness, decreased interest, decreased enjoyment. Sometimes people have more of a pessimism. They're thinking about everything that's going to go wrong. I have Parkinson's now, even though they're doing very well and their Parkinson's motor symptoms are managed well, and when they're depressed, they can be extremely pessimistic. And what's always been just most remarkable to me is how I can see someone who's minimally affected by Parkinson's, but has a horrible depression, a depressive disorder early on. And their depression gets treated, their mood disorder gets treated, their Parkinson's has progressed quite a bit in those 5 or 6 years, but they are able to enjoy themselves. They're not pessimistic. They feel like they're handling themselves. So a mood disorder really changes the lens that you look at the world through. People can also have inappropriate guilt, negative view of their sense of self, feeling unable to cope, the idea that you have no bootstraps. Sometimes I say that depression is a depressive disorder is the absence of bootstraps. And as someone starts to get better, their bootstraps start to recur. And irritability might be there. Again, these physical symptoms will also worsen with active depression, but it can be hard to distinguish whether those changes are part of PD or whether they're part of depression to make the diagnosis. Anxiety disorders are also common in Parkinson's, and we call them clinically significant. I mean, people can get anxious about all kinds of things, but we know that when someone has an anxiety disorder, it's not just an understandable reaction to having Parkinson's or, can I get across the street? There's traffic coming and I move slowly. It's not that. It's a more persistent and pervasive or problematic, clinically significant anxiety. Then often, and we already know, it can occur before Parkinson's even begins. So that in and of itself suggests that it's not only an understandable reaction to the Parkinson's disease itself. We also know that anxiety can occur along with depressive disorders and other mental health disorders, or it can be secondary to anxiety symptoms. If someone is having some memory difficulties or concentration difficulties, part of their Parkinson's, they can get anxious when they're put into situations that require them, say, to do their checkbook or do mental math. But they're not anxious at other times. So that's more of a specific or situational anxiety, but not necessarily a phobia, as I'll talk about. So we have several types of both typical, and what's interesting is we also have Parkinson's specific anxiety. So an episodic type of anxiety disorder would be something like panic disorder, where out of the blue, for no good reason, someone just has a panic attack, where you get worried, anxious, and then you have all these physical symptoms like feeling restless, facial flushing, etc. So that occurs in Parkinson's, independent of Parkinson's, but it can also have symptoms in Parkinson's that look just like that. Situational anxieties like a phobia, being afraid to be in crowds, being afraid to cross a bridge. As I mentioned, I had several patients who, as they were in their late 50s, 60s, they developed these claustrophobic situations where they couldn't, sit in a crowded church and feel they would just become extremely anxious. And then some anxiety conditions are actually continuous, things like generalized anxiety and PTSD, where someone can have symptoms, for example, worrying about what to worry about, which is what we see in generalized anxiety, or being vigilant about things that might be happening to make you anxious. Then we see these PD specific conditions, and that's been something that we've really become aware of over the years, where it took a while to convince the neurologists that we were seeing these conditions in Parkinson's, and I'll talk about that a little bit later with some other slides. But it's important to think about these PD specific. They are relatively common. So in our sample of 250 patients, 22% of those who were affected had anxiety disorders that really didn't fall into the usual categories. And that's when we started calling them PD specific. Others have had 11%. And we've now developed Parkinson's specific anxiety scales that can be used to evaluate anxiety and PD. All of the other ways that we had to evaluate it didn't really apply to Parkinson's. So we often wouldn't even detect anxiety. If you're doing a panic disorder scale and it's not asking about off-related symptoms, you're not going to necessarily pick that up. In looking at anxiety disorders in particular and how to distinguish them from depression, it's important to look at what are particular features of anxiety. And often they can be overlooked and people think, oh, it's just a depressive disorder. But a person with an anxiety disorder in the absence of depression, one, they're not going to have the sadness. They're not going to feel like they're not worthy. They're going to be interested in things, and they're not going to have those morbid thoughts or guilt. What they do have is apprehension. You know, should I bring 13 Kleenex to the appointment or should I bring 12 Kleenex? They anticipate the negative. If I go do this, something disastrous is going to happen. If I'm not going to be able to, get in the parking lot and get to the appointment. They can be overly detailed. They can be pretty reactive to things, fearful, and have a lot of somatic concerns thinking about their body. So the complaints that people will have when they're anxious about their Parkinson's may actually be greater than what the clinician would observe on their exam. And so sometimes what happens is people are getting extra Parkinson's medicines because they're having physical complaints, but that's really part of their anxiety. And so it's really important to make sure that anxiety gets addressed. What is the trickiest part, and I put the stars here with avoidance, is that's what often people don't realize about anxiety. If you're anxious about something, the best way to not be anxious is to avoid what makes you anxious. So if you're afraid to go out, you just stay home. And someone says, are you having any problems with anxiety? The patient says no, because they're not doing what makes them anxious. So we often have to ask very carefully, what is it you're avoiding or not doing because you're feeling more anxious? And it's this avoidance actually that, for example, people who have PTSD often don't come into treatment, because why would you want to go spending time to talk about what's making you terribly anxious, et cetera. So we really look for this avoidance, and that's something that I think people often it leads to overlooking anxiety or missing that diagnosis. Another condition is apathy. About a third of the time, it can be part of a depressive disorder. 10% it can just be on its own as an independent disorder. What you see, again, loss of motivation, emotional indifference, a reduction in taking part in activities, not because they can't, because of their Parkinson's or intellectual difficulties. It's because they just don't have that motivation or inclination. It can be associated with cognitive changes. The big thing about apathy is that the patients who have it don't complain. They're apathetic about it. It's usually the family that complains. My husband won't do anything. He sits around all day. He's not interested in things. He's not unhappy. He'll go to wherever if I bring him along, but he's not, he's not motivated like he used to. Another problem that we see quite common in neurological conditions, and you see it up to half the patients with Parkinson's, is something that we call emotionalism or pathological crying. And this is, you see it in depressive disorders when they're more, acute until they're treated. You can see it when someone has delirium or a confusional state. You can see it when people take certain kinds of benzodiazepine type medications like Valium. And what you see here is this heightened excessive sentimentality that's very brief, but often tears. Someone says, it's like if someone does a kind deed, or if someone thinks about their grandchildren or their love for their family, they'll have very sudden tears that then just go away very quickly after that. And it's not really a sustained emotional state. It's inappropriate. The person's often embarrassed by it, and they don't have any control about it. So that's something that some people will think, oh, I must have a depressive disorder. I must be depressed because I'm crying all the time. But what you don't see in people who have this emotionalism in the absence of a depressive disorder is you don't see all the other changes like feeling worthless or not wanting to be alive, etc. The sadness, just this sort of very quick, brief tears that often is embarrassing. Parkinson's psychosis consists of hallucinations and delusions. So I want to first talk about the overall presence of it. And it really depends on your definition of psychosis. It depends on who has Parkinson's in your study and who has some other condition that looks like Parkinson's, like dementia with Lewy bodies, or do they have cognitive impairment? So the overall rates are about 8 to 40%. Over time, symptoms will become more persistent and progressive, but there's something that I really think it's incredibly important to look for and to talk about with your clinicians so that if you notice any of these. And certain medicines with Parkinson's, like the dopamine agonists, can increase that risk, certainly as people age with the progression of PD. So looking at just hallucinations, a hallucination in its most simplest definition, it's a perception of something without something actually being there, without a stimulus. You can have them in any sensory domain. It can be most common visual in Parkinson's, but it can also be auditory through your ears, hearing something or tasting something, smelling something, or feeling something touch you. In other psychiatric conditions, it's more common to have auditory hallucinations. In Parkinson's, it's most common to have visual hallucinations. And we talk about various types. One is, they're called minor hallucinations, and they're not technically hallucinations, but it's a sense of presence, this vivid sensation that someone else is there. Someone will say, you know, my brother has been deceased for, 5 years, but often I feel his presence sitting in a chair, next to my bed at night. And it just brief occurs, and it's often not disturbing to people. Passage hallucinations are brief visions in one's peripheral field, seeing someone walk by, or maybe seeing a cat walk past the door, even when you don't have a cat. And illusions are really sensory distortions. It's where you might look at the curtains, and way they're blowing at night, it looks like maybe there's some other kinds of animal or a bear or something that might be showing up in there. So it's really, you kind of just have a distorted sense. And then hallucinations, someone can have insight or not have insight with them. Often people, when you first see something that's an hallucination, you don't have insight, and you have to check to see, okay, is that really there? They can be unformed, like a puffball that just floats around, or it can be something that is more formed and complex, like a little girl sitting at the end of the bed, or sometimes people have seen entire groups of people, out on their lawn. As I mentioned, they can be any sort of sensory domain, taste, and this is sort of a sense of your physical sense of where you are in space, kinesthetic hallucinations. So it's important to know what the rates of these are. So these are people who are treatment seeking for hallucinations or delusions. And so a delusion is defined as a fixed false belief that the person has, despite any evidence to the contrary. They're going to believe that no matter what. You can't talk them out of it. So hallucinations, again, I mentioned that visual were most common. Almost 100% of the folks in this particular treatment-seeking sample, auditory in about half of them, tactile, a quarter, could feel something touch their skin. It might be something crawling on it, and others had olfactory or smelling something that wasn't there. The delusions, again, in this sample, were about 76%. Most common were the idea that someone was stealing something, or that they were not in their own house. One symptom that's very common is are these beliefs about spousal infidelity. And this is often very difficult for family members to handle if you're taking care of your loved one and then they maintain that you're actually having a relationship with someone else. It's very, very hurtful. But this is something that does occur as part of the psychotic syndrome. Others may actually believe that their spouse is not who their spouse is, that there's an imposter coming in. You look like Jane, but you're not Jane. Last, I wanted to go over these PD medication-related mood syndromes. So I mentioned that earlier when I talked about the different types of anxiety. One is something called emo states, or early morning off. So a person wakes up in the morning and they have extreme anxiety, extreme low mood, And often along with that, some urgency, some of their urine and some drooling or and then some numbness and tingling or paresthesias. So this is something that people can have. When you have that, the treatment is actually to figure out how you can not wear off. It wouldn't be to treat a primary anxiety problem like panic attacks, et cetera. So it's really important to try to get those, sort that out. The dopamine agonist withdrawal syndrome, or DAWS, is where people are coming off of a drug like ropinirole or pramipexole, and they start having new onset panic attacks, in particular anxiety. They can even have severe depression or suicidality. And I've had several patients who've had drug cravings for dopamine agonists that really ended up looking like they had, they were like, one patient actually admitted to a substance use program. And he said, you know what, I didn't think I belonged here, but I realized all the things I'm doing for my Mirapex are the same as what these folks are doing for cocaine. So it was a very enlightening statement that he made. And then there are folks who have these on-off motor and non-motor fluctuations. And that's really this roller coaster ride where people start taking their medicines in the morning, say 6 o'clock, their mood is okay, not great, but maybe they have that early morning off. And as the day goes on, the yellow is their Cinemet. So they become a little, their neutral mood, neutral motor, become dyskinetic, but then their mood goes back down when they wear off. And then it goes back up as their motor symptoms get better controlled by the medicine. So if I see at noon, you're looking pretty good there, right? Your Parkinson's is controlled, your mood's pretty good. But by 3 o'clock, your Parkinson's medicine is worn off and your mood is, going down to the pits there. So the patients often don't recognize about this difference, but their families definitely do. So you have this fluctuating mental state that's like a roller coaster ride, where people get very depressed or anxious with the fluctuations in their motor situation. And along with those fluctuations, you have these autonomic symptoms: drenching sweats, hot sensations, flushing, things like you might see with a panic attack. A patient of mine, a male, said he developed menopause at his age, and it was, but these are his dysautonomic symptoms that he was having. People can also experience during those motor off periods of slowed thinking, along with anxiety, and then other sensory symptoms. Next and last, we have these impulse control and behavior disorders, which can occur. Certainly, they're associated with medications. And I mentioned compulsive, medication use in that setting. Individuals have developed gambling problems, hypersexuality, pathological shopping, and then punding, which is a behavior where someone does something kind of needless activity, but they do it over and over again, like taking apart flashlights and other mechanical equipment and then putting it back together again, or taking books off the shelves and sort of just fiddling with things and spending a lot of their time doing that. So what are the treatment approaches and options? So what I want to emphasize is that mental health treatments are only effective when they're pursued. And sometimes, you have to kind of get the whole course too. You can't just do it one time. It's something you got to stick with. We want them to be targeted, individualized, and collaborative. We often use multiple interventions and with different and multiple disciplines involved in those interventions. So it might be medications, it might be talk therapy, it might be rehabilitation therapy of various sorts. So I'm going to give you an example of what I might do. So here's a 70-year-old veteran. He has Parkinson's disease. He has a history of PTSD, history of major depression, which is not active right now, that I can tell that he said. And he has history of alcohol use disorder, but it's not a problem right now. And suddenly he comes in with new onset panic attacks. So I'm looking at what are my possible treatment options. So the first thing we do is we collaborate to try to figure out what he's actually having. So I ask him to take a 24-hour diary and do this for about a week. And you record hourly. What's going on with your mood? What's going on with your anxiety? Are you sleeping? How's your motor symptoms? Are you taking your meds? When are you taking them? And what are the circumstances? If it's, a person that makes you anxious is coming in when you have these panic attacks, the treatment's going to be different than if you're actually having non-motor fluctuations, like I mentioned. So these are folks that sometimes maybe they're a good candidate for deep brain stimulation, but I don't want to be starting to treat you for panic attacks if all we need to do is make sure we set a timer so that you're taking your medications on time. So we spend a lot of time educating, supporting to get a healthy medication and daily schedule. We do various behavior interventions. some stopgap approaches, breathing in particular. It's totally free. I love it. It helps with this whenever you're having anxiety or distracting activities, mindfulness training, physical therapy, physical exercise, as we mentioned, can be very helpful. And then we might do specific psychotherapies and cognitive behavior therapy, so maybe a PTSD specific therapy. And then we will look to see whether maybe we need to adjust an antidepressant if there are depressive symptoms. Maybe we need transcranial magnetic stimulation or even ECT. Maybe we need alcohol use disorder treatment because the alcohol actually use problem has come back. So these are all, it's much more than just saying, take a pill. We're gonna get you on this antidepressant. That's kind of the last thing that we do when it comes to treating patients with Parkinson's and their mental health issues. We kind of do everything before that. So that's where I came up with this idea. I was talking with a veteran one time, and he says, I just want to take this medicine. What do I do with this? Should I take 2 of them? Should I take 3 of them? And I was thinking to myself, this is kind of a mess. So the idea is, if your treatment is a mess, you won't be a mess. So the acronym is medications or medical, education, skills, and support. And you need all of those. So the M is for adjusting or adding or optimizing or actually taking the medications you're prescribed. Often, especially with psychiatric problems, people won't take the medicines. They say, I took it for 3 weeks and I was better, so I stopped. Well, of course, you're going to get worse again then. So we want to adjust and do all those kinds of things. And then avoid certain medicines that tend to make people worse. Benzodiazepines, antihistamines, drugs that are anticholinergics, things like Detrol, things that, and even people can take anticholinergics for their Parkinson's. Over time, they're not a good idea because they affect memory and cognition. Education, just like you're doing today, learning about your Parkinson's, learning about your symptoms so you know what you're dealing with. Lifestyle interventions, looking at your home, identifying what you can do to make your home safer and more compatible with who you are now. Learning certain skills. Psychotherapy is about skills learning. It's not, it's work. You don't come in and just, I make you better by listening to you. It is learning skills that can help you manage symptoms and prevent those symptoms from coming back. Just like you do when you go to rehab therapies, PT, occupational therapy, speech, etc. And then what I love doing is having people go into the home and sort of, seeing how they really are doing things and where their problems come up. And last, and it's so important, is social support groups, plus exercise, plus fun. That's key. Support, exercise, fun. So things like singing, dancing, yoga, etc. And then making sure that the other people around you are also getting that support. And then I added one more. The more I work in the VA and with veterans, you also have to be attentive to safety to falls, and safety in terms of harm to self or others. So the idea of, I won't talk about falls because we're talking about the mental health issues, but I can say that once someone falls, there's also a cascade of mental health issues that come. So I spend a lot of my work with the patient, making sure that their fall risks are addressed and prevented as much as possible. So the other safety issue is looking at suicidal ideation and suicide behaviors. It's not insignificant in Parkinson's. In one study, about almost a third of people had just thoughts about death a lot, or some people had suicidal ideation, and 4% had a lifetime attempt. We don't have any evidence that the deaths by suicide are any different than the general population, but we haven't looked at that specifically in veterans. What we do know is that when people have major depression, they are more likely to have suicidality, and they can be at greater risk of harm to themselves in that context. So since major depression is common in Parkinson's, we definitely want to make sure we treat it until it's better, until it's remitted, not just to get a little bit better. And when someone has risk of harm or violence to others, of course, it can also increase with when there's hallucinations or delusions or cognitive impairment. So safety and suicide prevention is really important. One of the things we do, in particular at the VA, is something called safety planning, which is and you can ask your clinicians to help you do that. You can find one online, but typically we do this with the veteran, where you become aware of what your distressing triggers are, symptoms or thoughts, things that are internal to you that only you know about. And you can think, that little symptom or thought has come to me. And when that happens, I'm going to do this. And then if things continue on and bubble up, maybe you need to do a little more. If that internal coping strategy hasn't taken, maybe you need to think about, well, what could I do else? Like maybe I need to go to a movie or listen to some music, or maybe I need to contact a trusted friend who knows what to do. We're really looking at avoiding crises. So often mental health treatment has been focused on waiting until someone is in the crisis. And what I want to emphasize with Parkinson's is part of your advanced safety planning is identifying these conditions very early on, and so that they can be managed and you don't have to get to the crisis. So suicide prevention, just to remember, time and distance are on your side. Many people who actually end up dying by suicide, those or who have attempts, those attempts occur within an hour of when they first had that. So if time can go on, or someone can distract you, or you can't get to where whatever your means of attempting to harm yourself are, you are less likely to have that be something you can act on. So if you're concerned about someone, whoever it is, you want to stay with them for that time, or for until you know that that person is safe. And we do something clinically, but you know, and anyone can do this. It's lethal means counseling, and finding out whether someone has weapons in their home, or what are the other means that someone might use to harm themselves. So whether it's medicines that they might try to take an overdose on, or some other way that they might try to harm themselves, we try to prevent them from having that available to them. And we really, really recommend using gun locks and having them for routine safety. Just in general, people have children around their homes, and et cetera. But also when someone is in more of a worse state, to temporarily remove those weapons from the home. And of course, the most important suicide prevention measure is to treat mental health conditions. In the VA, we have specific psychotherapies that we use for suicidality. In fact, we're doing them with the group up in New Jersey that works on Parkinson specific therapies. And then there's the Veterans Crisis Line, which is available to anyone. You don't have to be getting your treatment at the VA. So when you get these slides, if you would like to get some gun locks, you can email Corey Terhune, and he can send you those to your house. The key thing is, a locked firearm can mean the difference between a tragic outcome and a life saved. So just to finish up with talking about mental health issues, we know that mental health issues, like any other medical condition, can impact your overall physical health and your well-being. Your Parkinson's symptoms will get worse, your cognitive symptoms get worse, etc. But your clinician may not realize your mental health issues are important or relevant if you don't bring it up, or if you look pretty much the same as usual. And so many won't ask. So it's kind of a don't ask, don't tell. Well, we want to be telling. So if you have concerns that you want to address, bring those up first. There's some people use this phrase, it's called the hand on the doorknob sign. As the person's getting ready to leave the room, they say, oh, by the way, doctor, I think I'm going to be, I'm not feeling like I want to keep living. We want to bring that up very first, and so it can be addressed. You don't have to wait until you have an appointment weeks to months away. Call if you're experiencing changes. And often they're not actually related to the mood disorder. As a geriatric psychiatrist, it's very common to identify urinary tract infections or a side effect of medication that has affected someone's mental state. And it's not just their mood disorder or whatever else I'm treating. And the best practice really involve regular screening for mental health symptoms. I know VA and most other places will do regular depression screening, but if you have anxiety, that might not get picked up on on the depression screen. So if the tool isn't picking up on the problem that's kind of keeping you from having the life that you should have, or want to have, then you need to bring that up. And then some other tips for starting a conversation, are really, again, mainly just say it if you don't have another way, but you can always bring it as, you can call ahead of time and say, I want to make sure that Dr. Marsh knows I want to talk about this. There are families that would send me emails or call the clerk and say, I can't be at the meeting with John, but this is what I want you to know about him. But also often we talk about people having an informant or collateral information. So and knowing who that person is for you so that they can speak up for you if you're not feeling comfortable. Now, one of the things that's so important about VA right now is they've really, and Patrick mentioned this, is the VA whole health program. And that is a way that they will definitely be asking about how you're doing, how your mood is. And this is promoting these whole health principles focused on the patient's goals and looking at not necessarily saying, oh, I would like to get my depression treated so that I only have a bad mood 3 out of 8 days or something. And no, this is about, I would like to be able to, go on a trip to the Caribbean on a cruise, and I want to have the best time possible. So the purpose of the whole health is that you would be working on what is it you need to do that. So the goal becomes something that's more about your life and your whole health rather than just about symptoms. And we practice that in psychiatry as well. So the components of whole health are really, it's you, your self-care, things that you do, your professional care, and also your community, which is why I love the fact that we're doing this program that's involving the VA and the community, Parkinson's Foundation, you and other professionals. So again, this is just the idea. You're in the center of your care and being aware of what's happening with you, aware of your body, your personal development, your nutrition, etc. Then just to summarize, I've talked about mental health conditions and symptoms. They occur over the course of PD, including before it's diagnosed. So we need to be thinking about that. We need to recognize there's a variety of mental health conditions, each with distinguishing features. You can have more than one. Each gets its own treatment. And when treated, there are many options and approaches. The overall experience of Parkinson's will improve and people live a better quality of life. So at VA, we have a number of resources, outpatient care, psychotherapy services. We have psychotherapists who are specifically trained in working with Parkinson's disease and that are doing that virtually with us down to Texas and getting folks treated. We have additional resources if someone needs to be hospitalized. We have vocational rehab, homeless services, etc. So we have a lot of resources. It's really wonderful to work at the VA where I feel I have unfettered abilities to take care of people. We also have veteran service centers for veterans of combat zones or who have experienced any sexual trauma. That's another place to go for counseling or to have your family come in. And they work with the VA and coordinate, but your care can also be separated. And I believe though that's it for me. So I will end my slideshow. Thank you. And I guess that was.
Thank you, Dr. Marsh. That was fantastic. And your coverage of the different symptoms and the ways that they present and possible co-occurring mental health conditions has generated a number of questions. Next, we're going to hear from Gretchen Glenn, who will answer some of the questions we got through the chat box about service connection and evaluation. Gretchen is a social worker and Associate Director of Education of the Philadelphia VA Parkinson's Disease Research, Education, and Clinical Center, or PADRECC, as I mentioned earlier. She's also at the Corporal Michael J. Crescent's VA Medical Center and Chair of the National VA Parkinson's Disease Consortium Education Subcommittee.
Hello, everyone. So I'm trying to find where I can see these questions. So for those of you who may not know that Parkinson's disease and Parkinsonism is considered a presumptive service-connected condition for veterans who served in the Vietnam era and were exposed to Agent Orange. So you must have a Parkinson's disease or Parkinsonism diagnosis before you can file your claim. That was one of the questions. It's also a presumptive service-connected condition for veterans who were stationed at Camp Lejeune and due to the water contamination, and also for veterans who may have moderate to severe traumatic brain injury diagnoses. So if you feel that you fall into any of those categories, you should go on to the VA website, and I'll post it in the chat box so that you can all see it, so that you can see where and how you can go about filing a claim for service-connected benefits through the VA. To be eligible, this is just a side note, to be eligible to receive care at a PADRECC center for your movement disorders, you must be also registered for VA healthcare already. So be within the VA healthcare network and receiving care. And I can post those links as well for those who may be interested. And sorry, I'm reading, making sure I didn't miss anything. So those are the only instances that I mentioned before about Agent Orange and Camp Lejeune. There may be other instances as more research goes on that the VA may service connect for other veterans of other eras. The best thing that I can suggest doing in the meantime is connecting and doing an environmental health registry evaluation at your local VA. I can post that on the website in the chat box as well. And basically that's just an examination that's done at the VA that you might have concerns about being exposed to certain toxins, such as burn pits is a big one, some of the other different gases that you may have been exposed to, that if in the future, you know, it's good for the VA to have that information for the research purposes. And then if in the future they become presumptive service connected for Parkinson's disease, they would reach out to you to let you know. So I can post that in the group as well. I think that may have answered the questions. I don't know if anybody saw any others in the chat that you might want to point out to me if I missed them. You can also email the or send a message to the Parkinson's Foundation directly. If you have any questions about registering for VA healthcare or Agent Orange, and the Parkinson's Foundation can send them to me afterwards and I can answer them in email form. Thank you.
Thank you, Gretchen. We will use the rest of the time, approximately 20 minutes, for the questions that came through the chat. Coming together to answer your questions are Dr. Laura Marsh, Dr. Patrick Welch, and Amanda Janicki. Amanda is a licensed clinical social worker and Parkinson's disease information specialist on the Parkinson's Foundation helpline. Our goal during this Q&A is to provide broadly applicable information and resources so that you feel empowered as you navigate the available resources and services options. Please understand that given the complexity of today's topic, we won't be able to respond to every question or scenario that was submitted. If we did not get to your question, or you think a question after the presentation, you can contact the Parkinson's Foundation helpline at 1-800-4PD-INFO. That's 1-800-473-4636. Thank you so much. And at this point, we're going to turn it over to Amanda for the first question. Amanda, can you tell us about some of the resources available through the Parkinson's Foundation for veterans and care partners? Where would you direct people who are looking for information about managing symptoms?
Sure, thank you. My first suggestion would be to call the helpline. We can do some of the legwork for you in terms of finding the most appropriate or relevant resources. So that would be my first suggestion. Otherwise, though, our website does have a lot of information in different formats. So if you're someone who likes to listen to something or watch something, we have podcasts, we have webinars. We also have a lot of reading material, free booklets we can send you on the topic of mood. So website, helpline. We also, as far as care partners go, we do have some courses specifically for care partners. So that would be something else we can guide you to. But I'd say reach out to us and let us do some of the hunting for you to find some resources that really would make an impact for you, depending on what your situation is.
Thank you. Patrick, the next question I have is for you. What would you say to a veteran who is thinking about reaching out to VA for mental health support, or who may be experiencing depression and/or anxiety?
Thank you, Tracy. I think the first thing is the realization that a person has. You have to acknowledge that you do have an issue. I would suggest two ways of looking at it. First of all, if you are a combat veteran, reach out and find a vet center in your particular area. The vet centers are staffed by combat veterans, and the information that you discuss at a vet center is private. I like to call them the little VA. They're usually in a strip mall or something like that, as opposed to the big VA, which is, multiple story buildings. The second thing would be to go to the VA. And if you're not registered with the VA healthcare system, go into the service center at the VA Medical Center, bring your DD-214, get registered with the VA, and then in that meeting with the service center people, they will be able to assist you in setting up an appointment with a clinician. There's also the OIF, OEF offices in many of the medical centers, which is another place for someone to go. So there's 3 or 4 different areas for a person to get involved in the VA healthcare system.
Thank you so much, Patrick. And we'll make sure that those resources are available to the listeners today. Dr. Marsh, can you talk about the possibility or probability of a veteran of the Gulf War and Iraqi freedom and other campaigns throughout the last 20 years developing Parkinson's due to their service in these overseas locations?
Yes, I've been checking out the questions, and I'm really impressed with the depth of them. They're excellent, and that particular question is something that we are asking at our VA, and looking at that longitudinally. There are certain things that so there, plenty of people who went to Vietnam or who will go to Afghanistan or Iraq who do not develop Parkinson's. So it's not everyone who gets it there. But there are other things that are increase one's risk of having. So we know that if someone has had a head injury, that's associated with increased risk of Parkinson's. We know that people with anxiety disorders appear to have an increased risk. And I'm gonna add in this other question, which is about the dreams and the nightmares. And one of the things that has been fascinating to me is I work on the 6th floor, and our neurology clinic is on the 2nd floor. And we were finding that people who came up to the 6th floor were diagnosed with PTSD because of their nightmares. And on the 2nd floor, they were diagnosed with REM sleep behavior disorder, which is this condition where you have nightmares. Normally when you're dreaming, you have your muscles don't move. But people, when you have REM sleep behavior disorder, you get up and you're able to have muscle tone. So we don't always know. And this is a question we're asking very specifically as what is that overlap between REM sleep behavior disorder and patients with PTSD? And when we look at people who have REM sleep behavior disorder, we know that REM sleep behavior disorder increases the risk of someone having a synucleinopathy, or what I mean is someone with Parkinson's kind of brain pathology. So head injury and REM sleep behavior disorder are 2 things that might be part of it. So does that mean that you're going to get Parkinson's? Not necessarily, but it's something that we want to be monitoring for. However, in addition to monitoring, if you have symptoms of any mental health issue, you don't have to wait until you have Parkinson's to get treated. Because what we also don't know is if we treat your psychiatric problems when you're 40, and you exercise and you have good nutrition, can we actually stave off the processes? So any kind of disease, what happens, as you saw in that slide where I had, you've got all these other parallel processes that are going on in your brain that are helping you to compensate. Well, what if we shore all those up, just like you're in combat, right? You're not going to have just one team going in, you're going to have all kinds of approaches. So maybe what we can do is either prevent that transition to actually having full-blown Parkinson's. That would be the idea. You could be reversing the disease process, or we can slow that disease process. And that's really why early identification, screening for symptoms, identification, recognition, and early interventions and treatment. I actually, Patrick Welch, our veteran who's here, I wondered if maybe because he was getting his depression treated at the VA and getting it treated very effectively, and getting his PTSD treated at the VA very effectively until he started having the diagnosis of Parkinson's, maybe if he hadn't done that, he would have developed his symptoms earlier. I'm just speculating. But I think, so this is why I really encourage everyone to, if you have these psychiatric symptoms, get them treated.
Thank you, Dr. Marsh. Turning to Amanda, does the foundation have any specific resources for veterans who are recently diagnosed with Parkinson's?
We do. We have a newly diagnosed kit. That's one resource that we can mail out to you that's specific for people newly diagnosed. And several of our webinars, educational webinars, and other booklets are really relevant. So we would be glad to get you in touch with that. And then again, touting the helpline, but we get so many calls from people that have just been diagnosed and they don't even sometimes know what to ask, where do I start with this new diagnosis? They're trying to wrap their head around it. And we can talk with you through that and get a sense of sort of what are your concerns, and let's answer some of those questions, and let's connect you with local resources so that you have, you're starting to build your local community. So the answer, yes, we do have some newly diagnosed resources, a special page on our website that's just dedicated to people newly diagnosed. We have some tips on our website, actually written by someone with Parkinson's for someone newly diagnosed. So there's a lot out there for you to find on our site or for us to guide you to.
Does that include information for loved ones or caregivers of veterans diagnosed with PD?
Absolutely. There's a whole caregiver section on our site. Some of it's specific to people newly diagnosed, but same thing. I mean, our site's got a lot of info, but I say call us, let us know what's on your mind. Someone's just been diagnosed. And like Dr. Marsh said, you don't have to wait for a crisis. Call us when, things seem okay, but just to get a sense of what to expect or to feel a little more prepared, a little more confident, so that you know what's out there, what resources are available to you.
Thank you. Patrick, can you tell us about the things you do to raise awareness about Parkinson's within your community and why this work is so important to you?
I got involved with the Parkinson's issue even before I was diagnosed with it. A female fellow veteran had called me one time and asked me what I could do to help in her struggle with Parkinson's because she knew of my advocacy work. So I began doing the research, as I mentioned in the piece that I did. And what has happened now is I've taken my advocacy to new levels. I've gotten involved with our local media. We've had our Buffalo News in what they call their refresh section of the newspaper. They did a feature story on Parkinson's disease and veterans with Parkinson's disease. We've had radio stations doing interviews with me, so giving me an outlet there. And I'm offering to speak at any programs where people want to hear more about Parkinson's disease, what it does to veterans, and what the VA is doing to assist veterans in those regards.
Thank you. That's amazing. I also had received a question that asked about the use of VA whole health services, which, for those of you who don't know, include things like Tai Chi, yoga, mindfulness, and weight management. Patrick, can you talk about how you learned about these programs as well as the impact they've had on your PD management?
Yes, I serve on the Medical Center's Directors Advisory Board. I've served in that capacity for about the last 30 years through many different directors. And we have presentations at our bi-monthly meetings where different departments of the VA come in and tell us what they do. And we had the lady who runs our whole health program come in and do a presentation. And I got involved with her in finding out exactly what whole health does, what I thought might benefit me. And so we're having those discussions, and I'm looking to get enrolled in. I've done Tai Chi in the past. One of the things, because I've got leg injuries, I can't do a lot of yoga stuff, but they have a chair yoga program that for people with disabilities like I have is also a very good thing to do. So we're also publicizing that. And then the auxiliary area that is run is for the spousal support out of the whole health department, where they get engaged in providing information to the spouses of people with Parkinson's disease and help guide them in how to care for that person. So it's been a very, very good experience. They're very knowledgeable and they do a very good job.
Thank you. A final question to Amanda. Are these services or are there services available to veterans who have Parkinson's disease, but who are not combat veterans?
Yeah, absolutely. I mean, let us know what you're looking for, what would make your life easier, more enjoyable, lighter, more connected, and we'll help you find what resources might be out there. Like I said earlier, we'll do some digging for you to see what makes sense for you, and try to partner with the VA if we can, see what the VA offers. But there's a lot out there, and with things being virtual nowadays, there's so many more options that if it's not available locally in your community, you might be able to access it online. So I would say yes, and just reach out and let us know, what you're struggling with, what you're thinking of might help, or we can help you with that.
Thank you so much. In fact, thank you so much to Dr. Marsh, Patrick, and Amanda for the information that you've shared here today. And thank you to everyone for viewing and participating in today's webinar. We know that additional questions have come in, and while we were not able to answer them live, we will follow up with you to ensure that your questions are addressed. Before we wrap up, I'd like to highlight a few resources that are available. Specifically, the Parkinson's Foundation resources that you see on this slide. Make sure to visit parkinson.org/veterans to learn more. And on this slide, we have some additional information that is available through the VA. Be sure to go to parkinsons.va.gov to learn more information about the resources you see on this slide. Finally, once we close the webinar, an online survey will pop up on your screen. Your feedback is extremely important to us and helps us improve future webinars for the veteran community. You can even suggest future topics. We're very open to listening to what you have to say. Once again, this webinar is being recorded and will be available for viewing early next week at parkinson.org/VA 2022. You will also be receiving a link to the recording via email. Thank you for being with us today. We look forward to connecting with you again very soon.